Does chiropractic manipulation affect the central nervous system? Part 2. Now let's look at some studies using functional MRI and manipulation. The first study is immediate changes following manual therapy in resting state functional connectivity as measured by magnetic resonance imaging in subjects with induced low back pain. There were 3 groups of individuals, all of whom completed an exercise injury protocol to cause low back pain. They were then randomized into a spinal manipulation, mobilization, and therapeutic touch group. Resting functional MRI followed by post-treatment functional MRI, where compared to determine functional connectivity between or among different areas of the brain by matching their patterns on functional MRI. Because this study also measured pain, let's do a quick review of pain pathways other than the ascending spinal thalamic tracts. Ascending older pathways include those stimulating the brainstem and higher non-conscious levels, including the spinal mesencephalic, the spinal limbic, and the spinal reticular tracts. These are part of the composite of pain transmission so that functions other than pain localization occur, including activation of descending inhibitory pathways and the registration of the type of painful stimulus, memory of pain, and the emotional reaction to that pain. Knowing these predicts which areas would likely light up on functional MRI. And recall activation of the descending raphe-spinal and cerulospinal tracts, which inhibit pain, do so through serotonin and norepinephrine-mediated actions at the spinal cord level. This will explain expected areas of connectivity, such as the periaqueductal gray and various components of the limbic system. The researchers included a 100-point measure of pain. We see here that the initial pain level was mild. Changes might then be hard to determine with regard to effect size. The researchers state, quote, "However, we cannot conclusively assume these common shifts are more than natural history or that they are specific to a manual therapy intervention, as these potential confounds were not controlled for in the study design. The timing of these changes could be viewed as associative, but more work is needed in this area," unquote. So how is functional connectivity determined? Pattern matching. Do time-matched patterns for different areas of the brain show similar activity based on functional MRI? Specifically, they detected increased activity and connectivity with the following structures: the left somatosensory cortex, the right posterior insula, the left anterior insula and the left posterior cingulate cortex, the left posterior insula, and the left periaqueductal gray. And even more specifically, here are the results related to areas activated and therapeutic approach applied. Odd to have these paired areas of connectivity demonstrating increased activity with some approaches and decreases with others. What does any of this mean? Although all these areas can be activated by pain, it's unclear why these matched areas of connectivity are active together. Nor do the researchers connect any dots. The researchers admit, quote, "Although we found changes in functional connectivity, the within-person relationship across the primary and secondary outcomes were weak and inconsistent. Thus, interpretation of these findings to represent a mechanism of pain relief currently cannot be made," unquote. Before we review the next study, given it utilizes PET imaging, let's review the basic principles as it relates to detecting increases or decreases in central nervous system activity. Positron emission tomography measures brain metabolism or blood flow using radioactive tracer glucose. It's either injected or inhaled. Glucose travels to the most active brain cells where it emits energy, the positron. So here's our next study entitled Cerebral Metabolic Changes in Men After Chiropractic Spinal Manipulation for Neck Pain. 12 male volunteers aged 21 to 40 years were included in this study. Participants had to have neck pain and shoulder stiffness. Exclusion criteria were any serious pathology. No women were included due to concerns of radiation exposure. The participants were divided into a treatment and a control group. This was a crossover design so that from 1 to 6 weeks after the initial measure, the groups switched. The secondary measures included cervical muscle tone and salivary amylase. Note with the salivary amylase levels, the ranges of the standard deviation are close to the values themselves, which questions its value due to lack of precision and therefore predictability. Given the researchers tie together salivary amylase and sympathetic nervous system activity, let's focus on salivary amylase as a measure of sympathetic nervous system activity. The usefulness of salivary amylase as an SNS marker is undermined by the fact that the parasympathetic nervous system also plays a significant role in salivary amylase release, with synergistic effects on protein release with the parasympathetic nervous system and effects on salivary flow rate. In this review of amylase, the researchers state, quote, "We conclude that at present there is insufficient support for the use and interpretation of salivary amylase activity as a valid and reliable measure of sympathetic nervous system activity," unquote. For measures of pain, they used a numerical rating scale. Scores were initially low, and so therefore changes are hard to qualify with regard to clinical significance. And by the way, the chiropractic manipulation in this study was an activator. And now to the PET scanning results. In the treatment group, activated were the anterior cingulate cortex, inferior prefrontal cortex, and middle temporal gyrus. Decreased activation was found in the cerebellar vermis and visual association cortex. The researchers state, quote, "The cingulate cortex is involved in the generation of autonomic responses, and performance of relaxation tasks may elicit maximal activation in the anterior cingulate region. This region of the limbic cortex has been implicated in cognitive and emotional processing, and as part of the midline attentional system and the dorsolateral prefrontal cortex," unquote. So the logic of the researchers: lateral prefrontal cortex is deactivated during cognitive tasks, therefore it is possible that the prefrontal cortex is activated during relaxed conditions, and that activation in the treatment group may indicate a relaxation effect, so that taken together, salivary amylase levels and activation of the anterior cingulate and prefrontal cortex may be from sympathetic, quote, relaxation, unquote. Others carry results like these even further. Here's an excerpt from an ad for a presentation at a local chiropractic association meeting that illustrates how this information is being marketed to the profession. Quote, "The researchers will present the evidence for the connection of the prefrontal cortex and intelligence, movement control, pain processing, mental health, the immune system, and inflammation," unquote. In other words, the prefrontal cortex is involved in everything, and if we can affect it, we will influence everything. They then tie in the need for activation through chiropractic manipulation for, quote, correction of prefrontal activity in pediatric neurologic conditions such as autism, ADHD, and other disorders. But what we can't know, and the researchers can't conclude, is what the metabolic activity or decrease in activity in these central nervous system areas actually reflect with regard to physiologic or psychological effects. Because most importantly, there are no correlates to clinical improvement in any research regarding these conditions, nor any reflecting duration of effect past 1 hour. This speculation is reckless and potentially harmful in its false promise of hope based on implied scientific confirmation between chiropractic and the stimulation of important related areas of the brain. And now to function. Our next studies focus on strength as it relates to cortical drive. The first is entitled, "The Effect of a Single Session of Spinal Manipulation on Strength and Cortical Drive in Athletes." The second entitled, "Impact of Spinal Manipulation on Cortical Drive on Upper and Lower Limb Muscles." So what is a measure of cortical drive? With electrodiagnostic testing, there are some basic unifying concepts. If one stimulates the peripheral nervous system directly and also the central nervous system, one can determine the contribution or difference between them. In other words, is there a cortical drive effect of manipulation when compared to a peripheral contribution to muscle force contraction? And the one we will focus on is the most intriguing, entitled "The Effects of a Single Session of Chiropractic Care on Strength, Cortical Drive, and Spinal Excitability in Stroke Patients." The purpose was to evaluate the effects of a single session of spinal manipulation on maximum voluntary contraction and neural reflex excitability. Their hypothesis is that the maximum voluntary contraction will increase, and the V wave, which represents excitability of motor neurons from supraspinal input, will be greater than any change in the H reflex, which is a measure of the spinal reflex. The researchers state that, quote, the V-wave response is considered as an index of the cortical neural drive addressed to spinal alpha motor neurons by some. However, this is not universally accepted, unquote. Let's quickly review the stimulus sequence. Mild stimulus activates sensory 1 alpha afferents to alpha motor neurons. Alpha motor neuron stimulation travels to the muscle. The efferent activity is recorded as an H reflex. A stronger stimulus activates motor neurons without traveling the reflex loop. This is the M wave. So simply put, the H reflex is similar to a deep tendon reflex, and the M wave represents muscle response to higher levels of stimulation, and the V wave represents supraspinal input to the motor neuron pool. So the results in some researcher conclusions. Spinal manipulation resulted in a 54.5% plus or minus 93.1% increase in maximum motor evoked potential for the abductor pollicis brevis, and a 44.6% plus or minus 69.6% increase in MEP max for the tibialis anterior. Well, what should be obvious with the standard deviation ranges exceeding the mean or average is that in some cases that would actually be a decrease in strength. And we don't know to what degree a certain percentage, even as high as 54%, actually means if, for example, the initial measure was extremely small. In other words, if the maximum initial measure was, let's say, 1%, an increase to 2% would double the initial strength, but would not be clinically significant. The researchers state that spinal manipulation may therefore be indicated for the patients who have lost tonus of their muscle and/or are recovering from muscle-degrading dysfunctions, such as stroke or orthopedic operations, and/or may also be of interest to sports practitioners. These findings should be followed up in the relevant population. In other words, the researchers are suggesting that it should be used for anyone with weakness, regardless of whether it is muscular or neurologic, and regardless of whether that neurologic weakness is an upper motor neuron lesion or a lower motor neuron lesion. And remember, they're recommending this in stroke victims based on the very limited results of this study. Our next study utilizes transcranial magnetic stimulation, or TMS. TMS is a non-invasive method used to stimulate small regions of the brain. The procedure is performed by holding a magnetic field-generating coil next to the head over the brain area of interest. The coil produces small electric currents in the region of the brain just under the coil via electromagnetic induction. TMS can either be used as a measurement tool to assess cortical excitability or indirect estimates of neurochemical concentration, or as an intervention to increase or decrease the activity within a given region, and it's been used for migraine headaches, seizures, and depression. Next, temporal twitch interpolation. This is an electrodiagnostic technique of applying a brief electrical stimulation, which in the following study was TMS, to a muscle or nerve trunk during a maximum voluntary contraction. Purportedly, the difference produced by the stimulation evoked and voluntary contractions can be used to determine the CNS effect of activating the muscle. The first study is fairly representative of several using TMS, entitled Increased Voluntary Activation of the Elbow Flexors Following a Single Session of Spinal Manipulation in a Subclinical Neck Pain Population. Significant within-group and post-intervention changes were observed for the superimposed twitch and voluntary activation, which increased by 3% following spinal manipulation. No other significant within-group changes were observed. A decrease in the amplitude of superimposed twitch during elbow flexion maximum voluntary contraction following spinal manipulation suggests a facilitation of motor cortical output. And now again to pain. Although we have discussed pain in the previous two sections, let's move to a very specific measurement. In this study on a proposed mechanism for pain relief with spinal manipulation, it's postulated that temporal summation of pain is decreased. Let's examine the logic. The mechanism of back pain relief by spinal manipulation relies on decreased temporal summation of pain. This study used a real and sham manipulation group. In this study of low back pain, the pain scores decreased by 9% after a sham intervention. The results showed decreased brain activity following tonic pain in all frequency bands after the sham intervention, whereas no change in activity was seen after the chiropractic spinal adjustment session. So the measure of tonic pain in this study was repeated stimulus and the reaction of the central nervous system to that stimulus. The researchers note that their study showed habituation to pain following the sham intervention with no habituation occurring following the chiropractic intervention. They then suggest that chiropractic spinal adjustments may alter central processing of pain and unpleasantness, but they admit that this is antithetical to what is expected, which is that manipulation should increase habituation just like the sham demonstrated. They were clearly at a loss to explain this paradoxical finding. So let's try to summarize what this all means with regard to what we can and cannot infer from these studies. Some speakers at chiropractic conventions say that you only have to connect the dots. The evidence is there, clearly showing a direct relationship between manipulation and the central nervous system. But from what is known at this time, hypothesized explanations to render the results of a study cogent and attractive is only allowable in the discussion section of an article, not presented as a concrete scientific confirmation. Hypothesized explanations of the results of a study have no place in the conclusion of the article or abstract of an article, and if given at presentations, must be clarified as hypotheses. One might ask, what would clinically meaningful results look like? Well, it's fairly easy to state, yet hard to determine scientifically. A specific technique approach such as HVLA is applied to two groups, one with and without the disorder, and compared to a no treatment group. Results indicate that there is not only a change in areas that, quote, light up on functional MRI or PET scan, but actually clinical improvement in strength, pain, function, etc., and that these effects are tracked over time to demonstrate durability. To attempt to connect central nervous system changes in activity to the direct effects of manipulation, one must proceed through a scientific process to arrive at statistical significance. All research must pass through a complex filter to arrive at the answer of whether results are statistically significant or not. And this relationship to spinal dysfunction must not only be statistically significant, but simultaneously clinically significant, demonstrated through a strong effect size. In other words, people improve consistently with these functional changes. But instead we are at a time when the process has been simplified so that all that is needed is chiropractic philosophy and passion to confer scientific immunity and allow extrapolation of the limited evidence so that the statement is, spinal manipulation should be utilized for treatment and prevention of neurological disorders. So consider the audience. If a speaker says chiropractic manipulation affects the central nervous system, so we should be treating central nervous system disorders, the general practitioner may be exhilarated and say, I knew it. This explains all my wonderful results. But the researcher is confused. How is it a single treatment with short-term follow-up leads to this conclusion? Although it may seem benign to extrapolate these preliminary findings to clinical effectiveness, taking that leap of extrapolation beyond what is actually demonstrated with functional MRI results will be perceived as scientifically invalid and spurious. It then threatens our professional integrity. Other health professions, such as acupuncture, tend to report the results as preliminary, and they shy away from premature conclusion when presenting the results in the literature and at conferences. So, is the world less magical knowing there are no unicorns? Is chiropractic less of a health profession if we don't discover magical connections? I think not. Clinical results experienced in individual practices are motivating enough without having to weave intricate hypotheses together with vague study results to please the practitioner. So what does the future hold? The Human Connectome Project. It's a 5-year project sponsored by 16 divisions of the National Institutes of Health. It is, quote, the first large-scale attempt to collect and share data of a scope and detail sufficient to begin the process of addressing deeply fundamental questions about human connectional anatomy and variation, unquote. After years of collection and comparison, perhaps a more meaningful, consistent data set can be used when comparing to clinical trials of effect. Until then, it's only speculation.